Hello, everyone. So let's get started. If you don't know me or know much about me, I've been a veterinarian for a long time. I run a clinic in New York where we treat and deal with mostly hyperthyroid cats. So we treat them with radioiodine. So I end up treating a lot of cats, and a lot of cats referred to me for different things. So what I wanted to do today is talk about how we look at the cat and tailor the treatment to the cat, because not all cats should be treated with radioiodine, and some cats shouldn't be treated at all. And some cats are ideal for surgery and so forth. So I want to do this by a series of case studies to go through and give you some examples of true cats I've seen. So the first cat I want to talk to you is about Simon, who's a 10-year-old Siamese, who's referred to me for radioiodine treatment. When questioning the owner of the cat, the owner didn't notice anything. He didn't notice any weight loss, any polyphagia, hyperactivity, any of the clinical signs of hyperthyroidism. It was diagnosed at the time of the annual exam, and we talked about this morning, if you were at my lecture, where it's a good idea starting at about age 10 to start monitoring thyroid function every year, because it's a very common disease. So that's what the veterinarian did. But there was no weight loss, no loss of muscle mass, no vomiting, diarrhea, polydipsia, polyuria, and anything. So there was basically no clinical signs. On physical exam, Simon was alert, had a normal body condition, a normal heart rate. He had I could palpate a tiny little nodule, kind of more like just like a slip through it than really a nodule. On review of his records, the screening tests were normal, and his T4 was high normal at 3.1. So we did a complete thyroid panel at this time, which showed a high normal T4, a high normal T3, the free T4 value was high, and the TSH was suppressed. So we have an asymptomatic cat with a thyroid nodule that we can palpate, a normal T4, a high free T4, a suppressed T4. It's looking like very mild hyperthyroidism. And we talked this morning about TSH and how it should be suppressed in hyperthyroidism, because the normal cat, the T4 and T3 will feed back to the pituitary shutoff TSH, and this regulates normal levels of T4 and T3. The hyperthyroid cat, when they have that thyroid tumor, and all cats will have a thyroid tumor at diagnosis, they have a thyroid nodule. It's not just a magical hyperthyroidism. Many people that come to me for a radioiodine treatment, when we show them the thyroid scan that we do before treatment and said, there's the tumor, you can see it's a unilateral tumor or bilateral tumor. They've never heard the word tumor before. They think this is the diagnosis of hyperthyroidism, and there's no tumor there. Well, they all have a tumor nodule when we get it. But anyway, in a hyperthyroid cat, the high T4 and T3 feedback to the pituitary shutoff TSH, which should be very, very low. And that's what we found in Simon. So overall, the cat has no signs. It's, we biochemically, based on the thyroid function testing, he has early thyroid hyperthyroidism. We did a thyroid scan. A normal scan, you can see the cat's head here. This is the chest. This brighter spot here is the heart. The front legs are there. So they lie in their stomach like this. And when we get the top part of the cat, we always get the whole chest, because it can be carcinoma. They can metastasize, but not very commonly. So you see in Simon, compared to here's a normal cat, there's 2 lobes. He only has this one little nodule on the right side, the other side is suppressed. So now we have a hyperthyroid cat, very mild, preclinical, no clinical signs, a little nodule that we can feel and we can see in thyroid scans. So, and the thyroid cell ratio is a little high. That just means it's taking up more of the radioactive dye. So that all goes along with hyperthyroidism. So, what's the best treatment for this cat? He's a young cat. He's not symptomatic, right? So what should we do? So first, before we get too much into that, let's review treatment options. So there's basically 4 ways to treat this. We can use antithyroid drugs, which is by far the most common treatment used, methimazole. We can use Hill's YD, which is an iodine-deficient diet. Both of these are reversible types of treatments. If we stop them, the hyperthyroidism will come back. It doesn't stop the underlying tumor from being there. It's still there. It doesn't stop the tumor from continuing to grow, which it will. This is a progressive disease. So this is more of a control than a treatment. I'm not saying that that's bad, or good or bad, but that's what it is. Surgery, we're removing the nodule, the tumor nodule, radioiodine. Our goal is to destroy the tumor nodule. So those are definitive therapies. So surgery can be difficult in mild cases like Simon because it can be difficult at surgery if you don't have a scan to know if it's unilateral or bilateral for sure. And we remember with surgery, the main problem with surgical thyroidectomy, it's a very good treatment, but if we have to do a bilateral thyroidectomy, then we have to worry about parathyroids, and once you've induced hypoparathyroidism, you never want to do surgery again because it's a disaster. So, efficacy, remember that these two on the left, iodine diet, low iodine diet, methimazole, they lower the T4, they control hyperthyroidism, but they don't cure anything. The tumor remains, the tumor continues to grow. Surgery and radioiodine, they either remove the tumor or destroy the tumor. So that's more of a definitive therapy. So you can imagine that the success rate is better with definitive therapy because we're taking care of the problem. We're not trying to just control it. Advantages and disadvantages, really, it depends on the cat again and the owner a lot. Radioiodine usually works, but they have to stay. It can take a while to normalize, especially cats with severe hyperthyroidism. They have to stay in the hospital for a few days, generally less than a week, but depending upon what facility and state you go to. There's no adverse effects. Depending on your area, it's limited to, there's a lot of treatment centers in the Northeast. And the cost is probably the most expensive. Surgery is close behind, or maybe even more expensive in some cases. They usually stay a day or 2 in the hospital, and it works well unless there's hypoparathyroidism. And then long-term management with methimazole and stuff usually works pretty well, but you have to do monitoring and so forth, and we're not cured. But when we look at these, talk about the pros and cons of each treatment, I mean, there's some things that you have to think about. First of all, very basically, the cat's age. If the cat is in good shape and is 10 years old, that cat could live to be 20 potentially, or even older. So we have a long time to think about controlling hyperthyroidism with methimazole, whereas if the cat would be 18, we don't have to worry about that at all. Lack of clinical signs, that means we have plenty of time to deal with what to do for definitive therapy or control. Tumor size, a larger tumor implies we better be more aggressive with treatment. The higher T4, we better be more aggressive with treatment. When cats like Simon, we probably don't have to be in a big hurry again at all. And then we have to talk to the owner about what the treatment goals is. Do they want to cure the disease, or do they want to control the disease? Are they being told this cat has a thyroid tumor? Because many of the the cat owners that I see haven't been told. They're surprised when they get to me, and these are the ones that are ready to treat with radioiodine to destroy it, but it's never mentioned. So just, it's something to think about and have a conversation with the owner. So, Simon, this cat has no signs. Should we treat this cat at all? What are we treating? If we're treating with methimazole, why are we treating with methimazole? To lower a number when he doesn't have any weight loss or any other clinical signs? I mean, this could be a good one to do thyroidectomy because it's unilateral. We don't have to worry about parathyroid function. Or we could do radioiodine. But the problem with radioiodine is his uptake, it's not very bright. His uptake isn't very bright. So I would probably wait a little bit longer and just monitor if it was up to me. So should a younger cat or cat with a tiny goiter be treated differently than an older cat or a cat with more severe disease? And I would say probably yes, at least more aggressively in the latter case. And finally, are the owners told that this is a progressive disease? And I think most of them don't. I saw a cat yesterday. The cat's been hyperthyroid. This is referred from University of Pennsylvania. This cat's been hyperthyroid for 4 years. Now the cat can't be controlled with methimazole. And the owner says, I'm here because I want to know why my cat isn't being controlled, right? And I say, well, your cat's been hyperthyroid for 3 years. And he said, so? And I said, well, this is a progressive disease. It'll get bigger. And he says, no one told me that. And I'm telling you that so I don't have to hear this again. So let's just take a step back and talk about progression. All cats start with normal thyroids. They have normal thyroids. There's no hyperplasia. There's no adenoma. There's no tumor. They first they start to form these hyperplastic nodules, which advance to these more of these adenomatous nodules, tumor nodules here. And this is usually when we diagnose them in here. Maybe a little bit hyperplasia, but it's mostly adenoma by the time we see them. But if we allow this to progress, and the time to progression is variable. I mean, this could take many, many months, or this could take just 3 or 4 months. This could be very fast. It's really variable from cat to cat, but they will progress. And some cats will continue to progress. I'm pressing the wrong button. And become more carcinoma-like. They get more nodules. There's only 2 thyroid lobes, so there should only be 2 thyroid nodules, but all of a sudden we start to see more. And these become more carcinoma-like and more malignant. So this usually happens after 2 or 3 or 4 years. Now, will it happen to all cats that are just followed or treated with methimazole? And the answer is absolutely not. How often it happens, it's hard to say, but it can happen. So we did a study a few years ago where we looked at almost a little over 2,000 cats, about 2,100 cats, that came in for thyroid scans, and we divided these cats into groups based on how long it had been since diagnosis to when we treated them with radioiodine. So you can see here we treated cats, this is years since diagnosis, so 0 to 1 year, 1 to 2, 2 to 3, 3 to 4, and greater than 4 to 6. So we had some cats that were, most cats were treated relatively soon, but not always. So this shows the progressive increase in the tumor volume with time. So these cats that were treated longer had a larger tumor because their tumor had more time to grow and be larger. And this kind of shows what we just showed in the previous slide, where early on the tumors were pretty small, then with time they got larger and larger, and finally some became very large and extended into the chest and so forth. So with time, over these years, you can see that large tumors went up and then kind of dropped off as huge tumors started to come up in the kind of in the brownish hair. So the tumor's size grew. Intrathoracic tumor nodules, as these tumors grow, they get heavy and they fall into the thorax. So cats in the thoracic inlet or in the chest herself went up with time. Again, just because of the tumor size. And then suspected thyroid carcinoma also went up because with time, these tumors start to become more aggressive. And it's almost like colon cancer, where you have a small polyp in your colon and you go to the GI doctor every 5 years, and he goes in, he does a colonoscopy and removes that, and we're all set. If you forget to go to the doctor for 20 years, this can progress to colon cancer and spread and metastasize. The same type of situation with these. And these are thyroid scans from cats with suspected carcinoma. Now, I have to say suspected because we aren't biopsying them here. We're scanning them. They look, but if you look at, remember, there's 2 thyroid nodules normally. And look at this cat has 1, 2, 3, 4. This cat has 1, 2, 3, 4. So there's more nodules than there is thyroid lobes. That's why we think it's either extension or metastasis. So getting back to Simon. So which is the best treatment? Should we put him on anti-thyroid drugs? You could, but he's 10 years of age. He has a long time to advance and get worse. He has a long time for this tumor to grow. So, you could put him on methimazole now, but it's very, very likely that at some point you're going to want to do something else. And he has a lot of time to get very, very large and metastasize. So I would have a heart-to-heart and say that probably isn't the best thing for your cat because she's only 10 years of age. Do you want to do Hill's YD diet? You could, but again, probably wouldn't be the best. Many cats don't like this diet. It works if they'll only eat Hill's YD and nothing else, but most cats would rather not. My cat would rather die, I'll tell you that, because he's told me that. So surgery, could we do surgery? Surgery in Simon is an option because it's only unilateral. Remember, that would be an easy surgery to do now. It's a small nodule, it's not invasive, you could. That's an option. Radioiodine, as I talked about, I would probably put it off and let him get a little more hyperthyroid because it tends to work better when they're more hyperthyroid a little bit. I like that T4 generally to be above 6 or so, because that makes the tumor nodule hotter and it takes up more of the radioiodine. Otherwise, in these really mild cats, you end up giving them you have to give them a larger dose to cure them because the tumor doesn't collect enough of the radioiodine. And for radioiodine to work, it has to be taken up by the tumor and live there for a while. So case 1. So this is one scenario. But this is the common one these days. I mean, the old days, all these cats needed to be treated yesterday. Now we have these cats that there's no signs, and the owners say, I'm not really sure why I'm here, but my vet said my cat's hyperthyroid. I don't see anything. So let's look at case number 2. This is Leo, 11-year-old male cat. And he comes in for weight loss and chronic diarrhea for a year. His weight's down more than 1 kilogram. He has terrible diarrhea. His appetite's very good. And he's, to start with, in the past year, he's been treated with steroids, antibiotic, pancreatic enzymes with really little to no response. So the referring veterinarian couldn't feel a palpable thyroid. They did CBC chemistry panel and so forth. Some cobalamin, folate was normal, fecal negative, FELV negative. Nothing really was there, and so he did a T4, and it was normal at 2.6, but they added on a free T4. By dialysis, it was high at 68. So the referring vet says, finally, we have an answer. Your cat's hyperthyroid. This is good. We'll refer him to Dr. Peterson. He'll give radioiodine. It'll all be great. So, but he had treated the cat with methimazole, and there was no weight gain. Now we can do a methimazole trial, and we usually do this for kidney disease, but sometimes it's a good idea to do it for things like diarrhea too. Because if they're hyperthyroid and we treat them with methimazole and we lower their T4 to normal, we expect that we can look at their kidney values to see if they have mass kidney disease, which is common, but also in this cat, if they have diarrhea, we can see if the diarrhea gets better. In this case, it didn't. So that's a bad sign. So they refer this cat to me. I can't feel the thyroid nodule either. Everything else is fine, really. I don't really find too much. My next step, I did more of a thyroid paddle. This time, T4 was normal, free T4 this time was normal, not high. T3 was normal, and TSH was measurable. Remember that in hyperthyroid cats, you expect the TSH to be suppressed, not measurable. So to me, this was all normal. He was in my office. He was referred to me. So we did a scan, but first I want to talk about this. How can this cat have a high free T4 with a normal T4 if he's not hyperthyroid? And just remember, we talked about this morning. There are cats, whoop. I keep pressing the wrong button. There are, if you look at these suspect cases for, oh, I'm sorry, this is TSA. So if you remember that free T4 can be falsely high in some cats with non-thyroidal illness, and that's what we suspected here. This is just talking about TSH should have been suppressed. So we did a scan on this cat, and he has two normal thyroid lobes. So the thyroid panel says not hyperthyroid, and his thyroid scan says not hyperthyroid. So why did he have a high free T4? And this is the slide I was looking for before. With free T4 values, remember that in cats with non-thyroidal illness, especially those with GI disease, we can see a falsely high free T4. We do not understand why the same thing happens in people. So you can't just base it on the thyroid, a T4 alone or a free T4 alone. We talked about this morning, but in cats like this with GI signs, you really have to be careful. It's because free T4 can be falsely high even when T4 is completely normal. So I referred the cat back to the veterinarian. They did a full thickness biopsy, and it showed lymphosarcoma. So that explains a lot. And that's, so again, this was hyperthyroid referred to me that wasn't hyperthyroid. So that's case number 2. So the first one was this Leo was a real mild one, or the first cat was mild, and Leo is non-thyroidal illness. We talked this morning about examining these cats, and if you're a feline veterinarian and you don't have one, it's nice to have a basket to do the exam. And this is what I have in my office. Usually I put a towel in here, and then we disinfect these and spray it, and we have 2 or 3 of these. But this just shows the cat being in the basket. And I also have this hot water pipe that goes right up my exam room, and we put this cord around it so the cats, and we didn't get burnt by the water going through, but the cats like to scratch on it. So case number 3. This is Princess. She's a 15-year-old cat. So now we're talking about an older cat, very thin. She's been gradually losing weight for years. She was diagnosed as very severely hyperthyroid about 9 months ago with the 17.3, where normal goes up to 4. Because of the older age and the cost, which is also an issue to talk about with the owners, they decide to treat with methimazole, which I would completely agree with in this cat. So they tried oral, then transdermal, and the cat developed side effects with a rash on the ears, face, and the stomach, and then stopped eating and started vomiting. These are all possible side effects from the methimazole. So facial excoriations usually are around the head or the ears like these, and they can get fairly severe. And there's no treatment that I know of other than to stop the methimazole. So we switched to Hills YD. This cat was eating very well, so she ate it well. She was really hungry, but it didn't work. And the YD will work, but you have to give it only that diet, and it doesn't seem to work nearly as well in cats that are very, very severe. So this probably isn't that surprising. So she lost more weight, so they stopped the YD, and because we wanted to evaluate the cat off YD for a couple weeks, and referred to me for therapy. And the owner was worried that the cat was too old for surgery, so that's one reason they decided to come to me. So here's the cat. So, what's the best treatment for this cat? So we can go through them. He had severe reactions to methimazole, so that's out. We tried the Hills YD, that didn't work, so that's out. Cat's emaciated, he's severely hyperthyroid. If we're gonna do surgery, and the owner doesn't want to, but if they did want to, we'd like to take a cat that's euthyroid on methimazole, not hyperthyroid, right? So this cat's in no shape to go to surgery, so that's out. So that's really, we're only left with the radioiodine in this case. That's really our only viable option. So we did a workup, and this just shows T4 remains very high at 20.7. And if you look, we always look at the liver enzymes because they can be high with hyperthyroidism. So they're a little high, nothing to really worry about. We look at creatinine BU, SDMA if you have it, because of mass kidney disease. The fact that this cat has low creatinine is a good sign. Why? If this cat was this hyperthyroid and the creatinine was 1.5 or 1.8, it's still in the normal range. But remember, once we treat them and once we decrease GFR to normal, that creatinine will go up. So usually if we look at pre and post creatinines in all hyperthyroid cats, the creatinine will always go up a little bit. So the fact we're starting so low is kind of a good sign. So we did a thyroid scan. He has a huge nodule on the right side. So here's their bilateral, and this is right side. The left side we don't see. So we treated the cat with radioiodine well, loved our food, we discharged. The T4 was normalized by 3 months, and it can take a while for these cats with more severe hyperthyroidism to get better with radioiodine unless you give them, or really unless you overdose them. So this cat was still a little high at 1 month, but it normalized by 3. And the creatinine, as I said, increased from 0.5 to 1.5. We expect this creatinine to go up after we treat them because GFR will go down as it normalizes, because hyperthyroidism causes an artificial increase in the GFR. And we're also, remember, creatinine comes from creatine, which is made in muscle. And after we treat them, this cat had a lot of muscle wasting, and that'll start to come back, and he'll bring back his muscle, so that'll get better. So we expect the creatinine to come back. So that's a fairly straightforward case. Luna, marked weight, a 13-year-old cat, so kind of the average hyperthyroid age I see is between 12 and 13. So this one had marked weight loss, PUPD, polydipsia and polyuria, and a high T4. There is marked weight loss, and owner noticed a lot of both the thirst and urination had dramatically increased. The appetite was normal. It wasn't really increased that much, which is a little bothersome based on his marked weight loss, but he was clearly hyperthyroid. So we did our workup. CBC was normal. Chemistry shows a slightly high ALT. This is from hyperthyroidism. Really nothing to worry about when they're hyperthyroid. The BUN was 38, so that's a little high. The creatinine was 1.5, so it's okay, but this cat was hyperthyroid, so we have to look at that. The SDMA was also high, and the specific gravity was pretty fixed at 1014. So, and the T4 was 23, so very, very hyperthyroid. So we have a really hyperthyroid cat with a high BUN, slightly high SDMA, and a high normal creatinine. Again, remember that hyperthyroidism increases renal blood flow. It increases GFR, glomerular filtration rate. It makes the kidneys look better than they are. After we treat them, the GFR falls, the renal blood flow falls, the creatinine will probably go up. Remember, hyperthyroidism causes muscle wasting. We treat that, the muscle starts to come back, more creatine gets made, convert to creatinine, and the creatinine goes up. So we have to be worried that the slightly high BUN in this case, with the normal creatinine plus the very low body condition score and muscle condition score, and the 1014 urine specific gravity could indicate kidney disease. In fact, in this case, I would be very worried. I get a lot of referrals where the veterinarian says, oh, the creatinine is still in the normal range, it must be fine. Well, it's fine at that point, but it won't be fine once you make the cat euthyroid. So let's see what happened. So I talked to them and I said, let's do a methimazole trial. We're going to see how bad the kidneys get after we treat. So we started 2.5 milligrams twice a day. This cat was a little fractious when you start the pill. So the appetite became decreased, which can happen from methimazole. So we rechecked the cat, and the BUN remained normal. The creatinine actually fell, but the T4 was still 18.2. So we decided, well, this is kind of weird that we got high BUN one week and normal the next, but let's switch to transdermal for now and continue. So we did that. Rechecked in a couple weeks. Now we did the renal profile. The creatinine was still normal, but the T4 was down to 5.4. You can say, well, this is pretty good. It's down to 5.4. But to do a good methimazole trial, we need to make him euthyroid. If you refer to me for radioiodine and I can get you a cat that only is down to 5.4, no one would be very happy. So we want to get that cat euthyroid, and we want to keep him euthyroid for at least a month or so, because that's how long it'll take to get a rise in creatinine. So we raised the dose. We checked in 2 more weeks. He's tolerating the methimazole well at this point. Now the T4 drops to 0.5, and now when the T4 dropped too low, now the creatinine went up to 2.3. So now it's a little higher than we'd like, but still not too bad, but it is higher. So now we decided to maybe go down in the dose. But this kind of shows what I'm talking about. This is from an old paper that was published by Tom Graves out of Michigan State in the 90s, but it basically shows the GFR readings, GFR here, and we did here is normal controls, the GFR is normal here. They did a sham thyroidectomy, so they basically put these cats under anesthesia, woke them up, and then like a thyroidectomy. So they have 2 controlled GFRs. You can see them right here, 2 and like 2.2. Then they measured hyperthyroid cats. You can see the GFR is increased above normal. That's what we're saying. Hyperthyroidism causes the GFR to go up, and that's what they found. And then they did a thyroidectomy, and they did another GFR, and you see it's below normal. That's because they did a thyroidectomy and the T4 became subnormal and they didn't replace them in these cats. So here they're really dealing with hypothyroid cats here. So the bottom line is, when we do these methimazole trials, you can't have the T4 too high or too low. You want it to be in the mid-normal range, really, to do the best trial. So, does this mean that the 2.3 that she has she's going to end up with severe kidney disease? We can't really tell. So we lowered the dose a little bit and rechecked again. And finally, we get a normal T4 of 1.8, and the creatinine stays at 1.6. So our interpretation was this cat is doing pretty good. I don't think that she has really bad kidney disease, and we can go ahead with the radioiodine, which is what the owner wanted to do 2 months ago. Right? So I examine the cat, don't find anything too crazy. The cat's clearly hyperthyroid. The TSH is suppressed. Both the T4, T3, and free T4 are all elevated. And the BU and creatinine here are normal now. We see a large thyroid mass unilaterally. So we treat this cat, and the T4s, you can see, went from 20 to 1.2 to 1.4, 1.5. Over 13 months, the T4s fell to normal and stayed normal. And when you look at the creatinines went up, and by a year, the creatinine was 2.3, but still that wasn't too bad, and the cat did very well. So eventually developed probably a little mild kidney disease, but nothing too bad, and was very stable. So the take-home points here is a methimazole trial can be very useful, but it can also be a pain to do. It can be expensive to do. And they can be laborious. But we want to get that T4 within the mid-normal range, not high normal, not too low. So that can be a little hard to do. And the azotemia, when it does occur, it usually occurs by 6 to 12 months after treatment. It takes a while to get stable, to get the highest creatinine. And then it usually stabilizes. So we have to keep this cat hyperthyroid for a while. Case 5. This is Suki. Suki is a 17-year-old Siamese. She has a picky appetite. They're hand feeding. He doesn't want to eat very well, not as active, very PUPD, vomiting. There's obvious bilateral goiter. The thyroid lobes are pretty big. The T4 is clearly high. The creatinine, however, is 3.2. So she's quite hyperthyroid and already quite azotemic, like stage 3 kidney disease even before treatment. So what's the best treatment for this cat? We're not going to do surgery in this cat. She's 17 and she has kidney disease. We shouldn't do radioiodine. She's 17, which is fine, but her kidneys are very bad. We don't know what's going to happen after we treat with radioiodine. This would just be a disaster. We could treat with YD, but she's barely eating now. She's probably not going to eat the YD. It doesn't taste very good for most cats. So we're really left with methimazole. And that's what we did with this cat. She did not do well. She did not survive very long. And that's kind of what we see. The median survival is only, in this study, was only 178 days. So less than 6 months in these cats that were azotemic when we when they were hyperthyroid. So being azotemic when they're hyperthyroid, especially severely hyperthyroid as this, is not a good sign. So if the cat's already azotemic at the time of diagnosis, the prognosis is much poorer. And it's really important in these cats to avoid hypothyroidism. You don't want to overdose them with thimerosal, and if you would treat with radioiodine, we wouldn't want to cause hypothyroidism, because hypothyroidism will enhance the progression of kidney disease in these cats. We don't want to do that. So case 6 is Finney. So typical history, gradual weight loss, good appetite, hyperactive. The T4 is moderately high at 9.6, but very clear. The vet just had a discussion with the owner. They couldn't pill the cat very well, but they didn't want to do radioiodine. They didn't want to have the cat away from them for a week. They had children at home. They were worried about the radiation exposure to the children. These are all things to think about. So they decided to do a thyroidectomy. So they kept the cat, and they controlled the cat as well as they could with methimazole to go to surgery. They went to surgery, and the vet says the thyroid lobes, he found both thyroid lobes, but they were atrophic. They were very small. He didn't do anything other than look, because there was no obvious tumor. He repeated the T4 and it was still high. He said, I don't know what's going on, so he referred the cat to me. So, cat looks pretty good. There was a murmur, everything else, I couldn't feel a nodule either. So we did some bloods, and I did a complete thyroid panel. So this shows high T4, high normal, or high free T4, suppressed TSH, and a high normal T3. So the whole panel goes along with moderate hyperthyroidism. So we did a thyroid scan. Our normal cat here in the neck, this is where the thyroid should be, high in the cervical area, but right here. And if you look at the thoracic inlet, if we drew a line, the thoracic inlet would be about right here, or right about here. So this nodule is in the chest, and if you measure, do a line down the midline, do a line down the midline, it's right on the center. So what this is an ectopic thyroid mass in the chest. When the thyroid forms, it starts forming in the embryo and in thyroid pouch number 4, I believe, in the thyroglossal duct. And so it starts at the base of the tongue, basically, and it travels right down the midline to the cervical area where the thyroid is, and then splits normally, and it stops. But sometimes a piece can get stuck on the tongue, and sometimes ectopic tissue can go further into the chest. So in this case, he had an ectopic nodule, or ectopic thyroid tissue in the chest, which is not a problem at all in itself. It happens in about 5% of all cats in general. But this one, the ectopic nodule became an adenoma, but the cervical thyroid lobes remained normal, and they were okay. So we see this about, we see ectopic nodules in our hyperthyroid cats about, again, 3 to 5% of our cats have it. So we treated this cat with radioiodine, just a low dose. That's all he needed, and he did fine, and he was cured. So just remember, when you're feeling for thyroid nodules, if you can't feel them, sometimes that's because they're not in the neck. That's not where they are. The last case is Andy, I want to talk to you about. This one has been on methimazole for over 5 years. He did well at first, but it no longer works. He's not responding. We've gradually been raising the dose of the methimazole over these years. He did well for 2 or 3 years, and now he's gone up and up and up. So let's talk about how methimazole works. Methimazole to work gets taken up by the thyroid gland. You give it by pill or you give it transdermally, the drug circulates around and gets taken up by the thyroid gland. And within the thyroid gland, it blocks T4 and T3 production. It blocks the step in thyroid hormone production. That's how it works. So with cats that have been on methimazole a long time, remember we already talked about this being a progressive disease. The tumor continues to grow and grow and grow. The reason these cats get resistant to methimazole is very simple, and that's that the tumor volume is too big, and we have to continue to give more drug, higher levels of the drug, to get it taken into the thyroid gland to block all the tumor cells. There's more and more and more tumor cells with time. So that's why the dose goes up. And I'm sure you've all seen this where you have to make a dose adjustments and go up sometimes. Not always, but sometimes we do. Not all cats will grow at the same rate. Some will grow very, very slowly. Occasionally we have cats that don't seem to progress at all. But most of them will. So this cat was very hyperthyroid on methimazole, and because of that, he's eating well, but he's really continuing to lose weight, and he was referred to me for evaluation. So he's very thin, muscle wasted. There's a large goiter on the left, a large nodule on the left. He has tachycardia, some VPCs, so he's really not controlled at all. And off methimazole for only 1 day, his T4 is very high, free T4 is very high, TSH suppressed, and TSH was quite high. I can't read it for sure from here, but it was high, very high. So he's clearly hyperthyroid, and this is his scan. This is VD, so he's lying on the table like this. So you can't see his one leg is here and one leg is here. His heart's here, his thoracic inlet's here. So over here, leg here, head here, cervical area, this is all chest. So most of this tumor, this is what I could feel on physical exam, this is all in the chest. So he has at least 1, 2, 3 or 4 nodules. It's a mess. And this is what can happen in these cats when they're allowed to be hyperthyroid, controlled for a while on methimazole. Methimazole does not stop the tumor from growing. It does not stop progression. And half of the owners I see like that, they're coming in tears because they don't know, they were never told this. And here on the lateral, these are lateral views, so here you can see better. There's at least 1, 2, 3, 4 nodules. 1, 2, 3, 4 nodules. So remember, normal cats only have 2 lobes, so they shouldn't have 4 nodules unless they have, it's what we can call carcinoma. This is his chest, his neck radiograph, and you get an idea how big that tumor is in his neck with the trachea deviated dorsally because of this large size of the tumor. So, what's the best treatment of this guy? Methimizole's not working anymore, so we can cross that off the list. It's unlikely that YD would work. And now I say this, methimazole no, YD no, but if we didn't have any other options, no options. We couldn't, we didn't want to do surgery, we couldn't do radioiodine, no options. One thing I've done in some of these cats is used a combination of methimazole with YD. You never want to do that routinely in your average hyperthyroid cat because they will go profoundly hypothyroid. It's very, very potent, this combination of YD with methimazole. But in cats like Andy, where nothing else is working and you can't do radioiodine, you can't do surgery to help them, this will work for a while probably, or at least it's going to be better. But surgery for Andy would be tough because we'd be doing a thyroidectomy, right? And we're pulling tumor out of his lungs and so forth. So the best chance for him is radioiodine. So cats like this, the average dose that I give normally, if you look at the last 2,000 cats I've treated, it's about 2 millicuries or less. With Andy, we gave 30 millicuries. So they need much more radioiodine because of the big tumor volume and the fact that he's been hyperthyroid for long. So we treated him. It took a good month to 2 to get better, but it worked. Our goal here is to create hypothyroidism and destroy the tumor. So that was his thyroid scan before, and that's his thyroid scan after. We destroyed all the tumor. That was our goal, and then we started him on L-thyroxine. Again, just to show you again that with time, these cats, it's a progressive disease. These tumors tend to grow. Now, I see all the ones that have grown. In your practice, you probably don't see it nearly as many as I do. And some vets said they never have seen it, and you're very lucky if you haven't. But if a cat lives long enough, we'll see progression. and with time, the rate of carcinoma also goes up. So, what's the best treatment for hyperthyroid cats? There isn't one, right? It may be completely, one cat definitely should probably go on methimazole when you have a talk with the owner and you look at the age and other problems. On one cat, another cat should not go on methimazole. Some should maybe try YD and others, probably most shouldn't. Surgery, most vets don't like to do surgery these days, but sometimes it's good. Sometimes it works well, especially for unilateral nodules. Radioiodine has been stated it's a treatment of choice, and it's a good treatment for most cats, but not all. So you have to take each cat individually, get a good history, look at the age, sex, and how symptomatic they are and how severely hyperthyroid they are. And the end. Thank you very much. I'm happy to take questions.